Okay, so now I want to talk about pneumonia. 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 Not old monia, but pneumonia. See, you guys asked if I had any dad jokes. That's one. There you go. All right, so pneumonia. Let's talk a little bit about pneumonia. What causes pneumonia? Anybody? 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 No? Nobody gonna answer? Yeah, that's pretty typical. Anyway, the cause of pneumonia, infection. Infection. There's your problem right there. Infection. Okay? So, where we generally have people having a difficult time making a differentiation between something like a CHF or a pneumonia or even a COPD and a pneumonia or something like that is that they listen only to the lung sounds. They go, okay, lung sounds are wet. So that must mean CHF. Well, we already know that that's not true, right? Lung sounds wet equals CHF. No, not true. Not true, not true, not true. So don't believe it. Okay? So the lung sounds can sound wet. In pneumonia, the lung sounds probably do sound wet. And the lung sounds are usually wet because there's this green, gunky, nasty stuff. That could be yellow too. Let's put a little yellow in there, for artistic purposes. Maybe a little red too. What the heck? So anyway, they've got this. That looks like Christmas. Oh, pretty. You could almost draw a little there you go, a little tree stand on it, and it's a tree. It's an apple tree. Anyway, never mind. No, pneumonia is an apple tree. No. No. So these pneumonia patients, generally what's going on with these people is that they have some sort of an infection. It's not chronic. It's not something that they have on a regular basis. I mean, you could have people that have frequent pneumonias, but it's because of an infectious problem. That's really what it is, okay? So their lung sounds are usually wet. Their blood pressure, what do you think? What do you think? What do you think? And that one's kind of up in the air. Generally, I might even see that these patients' BP is low. It might be that their blood pressure is low because they are septic. And patients that are septic, and we're going to talk about sepsis more in the coming modules, but patients that are septic are chronically dehydrated. Okay, so when you think sepsis, think dehydration. When you think sepsis, think dehydration. When you think pneumonia, think there's always the possibility that this infection has gone further. Okay? So there's always that possibility, so keep that in the back of your mind. Well, heart rate, what do you think? What do you think? What do you think? I told you, heart rate's pretty much up in just about anybody having a respiratory problem. But you know what? I'm going to say it. I'll say it again. Here it is. When the heart rate drops, Bill's not happy. Yeah, that's me. Bill is not happy when the heart rate drops, okay? When the heart rate drops, the patient starts to become bradycardic. And I'm not talking about their heart rate goes from the 140s to the 90s because I'm treating them appropriately, but that they're actually decompensating. Their heart rate is now going into the 50s, something like that. And especially if you add that to a low blood pressure, you are in deep doo-doo, okay? Got to do something about this. Got to help these patients out, okay? So with these patients, chronically, they will be dehydrated. So many times you're going to see that their blood pressure is low and that their heart rate is high. There's always the possibility that the blood pressure is normal, especially if they're early in the pneumonia, or if we're talking about like a walking pneumonia where the pneumonia is really not bad enough that it's causing major hemodynamic changes. Okay? Skin. Here's important here. This is important. Skin. Skin is important. Bill said it. I'm going to believe it. That's just the way it goes, man. Yes, the skin is important, yes. But their skin temp and condition, hot and dry. Yeah, no kidding. Hot and dry, okay? They have a fever. Right? Right? Pneumonia patients always have a fever. Is that right? Not necessarily, okay? So here's something to understand about the way that the body can work is that the body can try to increase the temperature or even decrease the temperature in an attempt to sort of kill off whatever that infectious thing is. So if it's a bacteria or a virus or whatever. So when we have patients who are potentially septic, those patients could be hot and dry, right? Which is sort of what we expect with pneumonia. We expect them to have a fever, but they could also be cool and dry and essentially have a low temperature. They could have a low temp. They could have a below normal temp. So don't just get in that habit of saying, well, the patient is in pneumonia and he has a fever and that makes him septic. Well, not exactly, because sepsis can be seen on sort of either side of the spectrum. Sepsis can be seen in that sort of like 100-degree area, and even maybe that sort of below 97 area. Okay, so it could be in that 100 or above area, but it could even be in that 97 or below area, and so that is still sepsis, guys. Even though they're not feverish, that is still sepsis, and that is important to remember. Okay, so pneumonia is an infectious issue, right? So what do you think the real, like, kind of first line treatment might be for pneumonia? Yeah, antibiotic. Now, I know you guys carry plenty of antibiotics on the truck. You got Rocephin laying everywhere, and you just got antibiotic after antibiotic just laying around the truck, right? Yeah, no, we don't carry antibiotics. No. So, yeah, that's going to be an issue, isn't it? So we're going to treat our pneumonia patients by obviously taking them somewhere where they can get an antibiotic, hospital, whatever. But at the same time, we want to treat any underlying issues. So what happens if my pneumonia patient has an end-tidal CO2 that looks like that? Well, albuterol is a good choice. Albuterol 2.5 milligrams, good choice in this patient. Can be a definitely good choice in this patient. Atrovent. Now, just like in chronic bronchitis, I'm going to put stars here, okay? I'm not saying that it's contraindicated. I'm just saying be careful. Now, it's not necessarily a bad thing in a pneumonia patient to give them an Atrovent. However, if I'm drawing secretions down in there and I'm drying up all of that green, apple tree looking stuff that's coming out of there, if I'm drying all of that stuff up, then apple tree, so cute. Then that's not necessarily a good thing. I don't really want to dry all of that gunk up in there. What I really like, I got to be honest with you, I really, really like humidified oxygen for these patients too. I like humidified O2 for these patients. I think it works really great. You could use an anti-inflammatory. If you've got a Solumedrol or we haven't discussed Decadron yet, but that's always a possibility as well, right? So using an anti-inflammatory, I think that's perfectly fine. That's good for these patients. It might help these patients quite a bit. Generally, if you have a patient with something like a walking pneumonia, they will probably prescribe some form of an antibiotic, okay? They'll usually give them albuterol if they don't already have it. They'll give them an albuterol. And then they'll usually give them some sort of an anti-inflammatory, either an inhaled steroid or even an oral steroid. So they might give them that. That's sort of a normal treatment for a patient who has pneumonia. The other thing that they'll tell them to do is they'll tell them to breathe in humidified air. You can take, when my daughter had pneumonia, I just took her into the bathroom and I steamed the bathroom up, and that helped quite a bit. You'll also find that that'll help with your asthma patients too. So giving them some humidified O2, I think, is a great way to go. You can do that with normal saline if you want to do it with normal saline, sterile water, whatever. Works great. Definitely seems to help the patient. But I cannot stress this enough, and I'm going to say it, I'm going to say it again, I'm going to say it again and again, and you'll hear it again when I'm back from Florida. We'll talk about it. This patient is septic or potentially septic, right? If this patient is potentially septic, they need fluids. They need fluids, guys. They need fluids. They're dehydrated. These patients, if there is the potential that these patients are septic, not necessarily that they're going into septic shock, although they may be, these patients need fluids. You need to give these patients fluids. Now, be careful, obviously. You are clinicians now. You don't just go, well, how much fluid do I give, Bill? You give enough fluid to get the desired effect without flooding the patient, right? So you really have to monitor your patient. But generally where I sit is I'll sit in about 500 to 1,000 milliliter area. Okay, so maybe 500, maybe a 500 bag to a liter bag of fluids for these patients. Okay, it's got to be protocol specific, of course, but these patients are good patients to go ahead and give them fluids. You don't want to fluid overload anybody, but think about it. If you've got a person like me, I'm 41 years old and I've had pneumonia a couple times since I've been up here in Wisconsin. They've given me fluids. I took 3 liters of fluid in the ER one time. So fluids. Obviously be careful. If your patient is elderly, they may not be able to handle them. Also, if they have comorbid factors, they might not be able to handle those fluids. So most definitely be careful in those patients with fluids, but you want to go ahead and give these fluids. So if the patient is potentially septic, fluids is definitely what you want to go with here, okay? Making a good differentiation between a patient that's having a problem with something like pneumonia or patient that's having a problem with something like CHF or even COPD or even emphysema, really what it's all about is history taking. Patient history. Patient history is what really gives you the idea as to what's going on with your patient. And that's what you're doing right now in clinicals. You should be out there talking to people and learning about people and learning about medications they take and all of those kind of things. You should be learning about those. That's really the focus here and in clinicals right now, is learning how to talk to patients and taking a really good patient history, because it makes a huge difference. So, all right, well, that's all I've got to say right now on pneumonia. We may talk a little bit more about it. Oh, wait, hold on. Let me add one more thing. No, God, please, Bill, don't. No, I was just getting used to the idea that it was over. Pneumonia, so you'll hear this a lot. It's one-sided. Hogwash. Bullshit, whatever you want to say. One-sided, not necessarily. Get that idea out of your head. If you're like, well, it's one-sided, so it has to be pneumonia. No, absolutely not. Pneumonia can most definitely be two-sided. It's called bilateral pneumonia. Okay? It can also be one-lobed. Yes, it could in fact be one-sided. Sure, it could. But if that's the only thing that you're using to determine whether or not your patient has pneumonia, you are doing it wrong. Okay? So it could be one-sided, it could be two-sided, it could be one-lobed pneumonia. All right? It could just be one of the 5 lobes that's got pneumonia in it. So don't rely just on that one-sided idea. Okay, it can definitely be bilateral and it can definitely be just one lobe. So, all right, well, that's it. Yeah, sorry I fooled you the first time around, but that's what I've got for you on pneumonia. I hope you enjoyed it. I hope it was at least a little bit entertaining. Take care.